Hi, it's Dr. Centeno, and thanks so much for joining us here today at You've Got the Power. I'm going to talk today about the lateral AO oblique ligament and what it has to do with craniocervical instability, how it helps to stabilize the head on the neck as we look up, and just in general what it does, how it might get treated, what types of CCI it's associated with, all that good stuff. As usual, I'll give a short presentation, then I'll answer questions. Again, today, if you're just joining us, we're talking about the lateral AO oblique ligament, which is sort of right up front, deep in here, and helps to stabilize the head on the neck as we extend or look up. Without further ado, I'll start that presentation, and then we'll get into questions after that. So let me go ahead here and share my screen. Looks like that worked, and we'll get into this ligament here. So what is the lateral AO oblique ligament? So this is a ligament that lives in the front of the neck. So you can see here that, let me get a pen, that this is the skull up here. This is the roof of the mouth there. We obviously have teeth. Now the lower jaw here has been removed, so we're looking directly into the spine. So this is going to be still the skull, C0, then C1, then C2. What's interesting about the lateral AO oblique ligament is that it goes from the transverse process here of C1 up to the front of the skull. And what's also interesting is that the AO ligaments, and we inject these a lot posteriorly, also go and start the same place at that transverse process and also go to the skull, but they do so in the back. So this is almost like that one's called the lateral AO ligament. And again, that one can be injected posteriorly. Now that's a hard one to do posteriorly because the vertebral artery lives right there. So you have to do it with contrast and digital subtraction angiography, but we do it all the time. It's not part of routine prolotherapy, but it is an important stabilizer of the skull on C1. And in the same way, since this starts the same place of the transverse process and goes to the skull, this is its anterior equivalent. Now, the problem here is getting to this one, especially the meat of it here in the middle, really can only be done from the front. So what does this thing do? What kind of CCI might damaging this ligament be associated with? So as you know, I developed this typing system. And again, to review, type 1 is C0, C1, that level, type 2, C1, C2, type 3, C2, 3. And these are the types of type 1 instability that lateral AO oblique ligament would be associated with. So the first one is going to be obvious, right? That's going to be angular instability in extension. So we know, and we can draw out here, that ligament goes from there to there on the sides. So if, as you bring your head back, it's going to get stretched and it's going to get tight. So if it's damaged, it's going to allow too much skull extension. And these are the people that feel like their head is slipping off if they go to look up, or they get lots of symptoms when they look up. Now, not all of those people have this issue, but this is one of the things that we would look at. And another component of that, right, would be, again, if we draw where that ligament goes, it's going to also control skull sliding. So this type 1C is when the skull slides on the atlas. And here we see it sliding backwards in extension. So the lateral AO oblique ligament is going to, again, start here, go there, and it's going to help prevent that skull from sliding backwards. Now remember, this one's associated with a condyle that isn't a ball and socket, but more flat. And then finally, this C0, C1 rotational instability, or type 1D, is also going to be involved here, right? Because this ligament is going from here up that way and here up that way. And as you might notice, that's going to prevent the skull from rotating. The other ligament that's also highly involved in that would be that lateral AO ligament. Lateral AO ligament we can hit posteriorly. This one we can't. And then the other thing that's going to be important there would be this C0, C1 facet joint capsule. That's going to be in the least great position to stabilize, right? Because if we have our moment arm farther out, then that's going to provide better stability. So these ligaments here, the lateral AO ligament and the lateral AO oblique ligament, would be the ones that provide the primary stability in C0, C1 rotation. So can this ligament be injected if it's having issues? And the answer is yes. We've now done this. I've been doing this now personally for about the last 4 months or so, hitting this ligament in patients that have issues with extension. And that's that PICL procedure, level 5 procedure, where we're coming from the front is the only way really to get there. It has been very helpful for that patient population. So in summary, this ligament lives in front of the neck and goes from the C1 transverse process to the skull. It prevents skull extension and rotation and somewhat skull sliding and extension. Ligament can be involved in type 1, B, C, or D CCI, and it can be treated with a PICL procedure. So let me stop sharing here and see if we've got any questions that I can answer. I'm going to discard those and see what questions we have here. Submit advanced by DB. What kind of tests would be needed to rule this issue in or out? You know, generally, the two things that we would look for would be a digital motion X-ray or upright flexion extension MRI. Those would probably be the best. Let me show this one here. Can mild disc bulges cause the neck to feel unstable? Yes, but not usually directly unless there's a lot of degenerative disc disease. So realize when there's degenerative disc disease and we get flattening out and loss of disc height, that can cause instability. But more commonly what we see is a disc bulge hitting a nerve. And remember, that nerve supplies the local stabilizing muscles. So that can cause a sense of instability all by itself. Regenetics been advanced by Harry Winston. Is this associated with CCI, or is this something that may be an issue instead of CCI? No, associated Harry with that type 1 B, C, and D CCI. Diana, hi, Dr. Centeno. Do you see patients get worse than the PICL compared to baseline? I mean, we certainly have, I think, Diana, as I've said lots and lots of times here, about 5% of the PICL population that gets a long-term flare in that 3 to 6 month range. So that's about 1 in 20. Now, that number appears to be going way down now that we no longer hit centrally sensitized patients as hard. So my guess is, where will that number fall? Maybe 1 or 2 in 100 is where it'll end up. And then with the vast majority of those patients converting at somewhere between that 3 to 6 month time period, either back to baseline or they got better. So the answer is yes, we certainly do see long-term flares. It used to be about 1 in 20. I think now it's trending to about 2 in 100 because we're being much more careful about how much of a procedure we do based on the patient's central sensitization. I think I'm saying that correctly. I did tilted open mouth x-ray, and it seemed to me that alar ligaments in C2 is loose because the distance between the den C1 is not the same on the other side, but C1 doesn't slide out of C2. Yeah, so we don't look at just the distance between the dens and the atlas. We also look at the amount of overhang. So we need to see both of those things in order to call the alar ligament as loose. So it can't just be one or the other. Regenics, mid-advance by Gerald Mosley. I was seen by one of the best neurosurgeons in Europe, and I was told I need surgery for this issue. Can you treat it to avoid this surgery? Gerald, we would need to take a look at your imaging to answer that question. We see a lot of patients who have been told they need surgery. The good news is that for the vast majority of those patients, we can help them. But obviously, every single patient is quite different. So we're going to need to take a look at all of your information to make sure that we can help you. So that would be getting in touch with my office or Carla, who can go ahead and help you set up a telemedicine. Diana, why are some patients' stem cell count so much higher than others? Some have low counts even with diet, etc. Yeah, well, we're not really looking at stem cell counts. So that's the first thing. We're looking at total nucleated cell counts, of which a small fraction are stem cells. So when it comes to total nucleated counts, those are pretty widely different. In general, they tend to be higher in younger patients. They tend to be higher in active patients. They tend to be higher in men versus women. So if we look at that, for example, the two ends of that spectrum would be a 25-year-old, very highly active male versus a 60-year-old female who hasn't gotten out of bed in 2 years for more than an hour or two a day. Those are going to be dramatically different counts. In addition, women that are perimenopausal, before, during, and after menopause, tend to have lower cellular counts. So cellular counts are all over the board. Now, I don't think cellular counts at all have anything to do with success with this procedure, simply because I don't think this is a total nucleated cell count sensitive procedure. So I know patients are really into this, but I don't think that correlates for this particular procedure. So it's almost one of those things where it doesn't make a difference to me what your count is. Now, if we're treating a knee for knee osteoarthritis, that's a different story. We'll want a specific count, but not for this application. Andy, if a patient has moderately lax C0, C1 facet capsules, but everything else is normal, not atrophy, normal alar transverse ligaments, can it cause any issues like heavy head feeling? I'm not quite sure how you would get to a diagnosis of moderately lax 0-1 facet capsules. I don't think you can get to that diagnosis with any imaging that's out there. So I'm not quite, you'd probably need to give me more information about what's going on there and how that diagnosis was made. John, clicking, cracking, and popping in my scapular region when rolling my shoulders. Will PRP help with this? It could. Yeah. I mean, the bottom line would be what's causing that, right? If it's being caused, for instance, by just weakness around the shoulder girdle, obviously strengthening the shoulder girdle. It's being caused by swelling in the scapulothoracic bursa, then you might get a direct injection in that scapulothoracic bursa. If it's being caused by irritated nerves in the neck that are causing weakness in the shoulder girdle, then you have to treat both. If it's being caused by tendinopathy around the shoulder girdle, then you've got to treat those shoulder tendons. As you can see, each problem carries with it a different treatment strategy. Duct P. So if I got this correct, a mild disc bulge causes muscle inhibition that causes neck unstableness. If the inflammatory irritation is mild, can strengthen these local muscles, resolve this. Well, not quite so simple. So it's a disc bulge that causes nerve irritation that causes the muscles to turn off. So that's the first thing. And yes, in some instances, just strengthening can sort of break that cycle. But in other instances, you've got to calm down the nerve, and that's more direct treatment of the nerve through injection. Amane is pressure, or Amane is pressure and puffiness under the eyes, a symptom of CCI. Pressure headache can be, but puffiness under the eye is not one we hear a lot about. Mercia, how could CSI or CCI cause skin to be very itchy? My skin looks normal. Dermatologist didn't notice anything wrong. This is one of the symptoms. This is one of the symptoms I have CCI. Well, usually not associated with CCI. Now, what we can see is hypermobile EDS patients who tend to have more frequent occurrence of MCAS and things like that. And obviously CCI can be associated with HEDS. And so HEDS is associated with MCAS. So that's probably how that runs. Robert, does the LAOL have more effect on CXA than capsules? Yeah, it would be in a much better place to do that, because you got to remember, Robert, that facet capsules would be one of the weakest stabilizers because they're right there towards the midline. So anything that's toward the midline is going to have less of a moment arm effect on the total structure. And the reason why we see in the spine all of these lateral ligaments, so the interspinous, or I'm sorry, not the interspinous, but the intertransverse ligaments, another example. And then we see these two lateral ligaments going up here like this, the lateral AO ligament back here, and the lateral AO oblique ligament up front, is because they've got a better moment arm that's farther from the center of movement. So they're going to have more of an impact. Now, this is a relatively new ligament that was just discovered. So for instance, when Dvorak did his studies on all of this, they had no idea this ligament was here. And certainly didn't do anything to cut it and look at any of that. But it would have a better stabilizing moment arm than the facet capsules would. And realize there we'd be talking about the anterior facet capsules. And the anterior facet capsules obviously can't be reached from the back. You can only reach them from the front. But we've gotten those as well in some of these LAOL patients. Diana, can intense meditation calm the nervous system and thus reduce central sensitization? That's a good question. I don't know the answer to that one. I mean, meaning we haven't really seen a lot of patients try it. I would be interested as well in that, because, you know, there's intense meditation, i.e. the type that's practiced in India, etc. So is it possible that that could impact central sensitization? It's possible. I just haven't seen any patients really try it at that intensity level. Andy, can mildly laxalar ligaments be themselves the cause maybe of heavy head feeling, or is the progressive atrophy of the segmental muscles that usually cause this? Yeah, Andy, usually both. So we tend to see those two things go together. So realize that half of that stability equation is ligaments, half of that stability equation is muscles. So the answer is both can cause that. You know, realize that that effect of having muscles turned off is pretty powerful. You know, we've seen patients, for instance, with cervical stenosis who bang against their cord and then they can't lift their head for an hour or so. And then after that, it all sort of turns back online. So just realize that it can be pretty powerful. It's been advanced by Sherry Scott. With the type of CCI we're dealing with be determined by our online evaluation with you or when we arrive in Colorado. A bit of both. Obviously, looking at the imaging is one thing. A lot of times we don't have all the imaging necessary on an online eval. Hence, those people, we need to get additional imaging and review it with them in Colorado. The physical exam certainly adds a piece to that because it allows us to identify which specific levels seem to be a problem. It also allows us to identify which specific movements seem to be a problem. And all of that gets put together to determine which ligaments to target and which types of CCI are there. So for example, Carla and I might talk about what types are there during an online evaluation, but then we get into the office and, these days, if you're in a eval or if you've been through an eval, you've probably heard me sort of barking out the numbers 1B, 2B, 2A, 3A, etc. So we're typing it as we go in order to know which ligaments we want to hit. Amen. I'm going to go with amen. The C1 doesn't really overhang my C2, just distance to the dens. C1 is different. Is that considered CCI? Usually not. Usually you have to have both that change in distance between the dens and the atlas and that overhang to be considered CCI. We tend to see some change in that distance because realize that the C1 and C2 are moving or rotating against each other, and that just by itself can change that distance. Wendy Nye, have you ever worked with a patient with congenital absence of the C1 posterior vertebra? Yeah, let's see. We've seen probably about 20 of them or so through the years. The first thing we usually do is get a high field head coil cervical MRI in order to look at the ligaments, main ligaments, alar transverse, accessory, et cetera, to make sure they're all there. Almost always they are, but we always like to check because theoretically, if someone wasn't born with a piece of something, then you've got to look for the other somethings to make sure that those are all where they're supposed to be. Andy, for the laser tracking exercises, how would this reverse the atrophy in the suboccipitals? Don't muscles typically need to be aggressively loaded, more weight to cause microscopic damage for growth? Well, you'd be surprised. Realize that the laser exercises are sort of very, very low level stuff. So the answer is you would graduate from the laser exercises and then start doing more aggressive work that would be guided by a physical therapist and a very specialized one at that. So that would get to your progressive loading, but realize in our patient population, I would say probably 4 in 5 patients can't get through the laser exercises without quite a bit of treatment. So even though it seems like it's low level stuff, and it is, and if you graduate it, I would agree with you, you'd want to progressively load. It's pretty challenging for our patient population. Jennifer, workers' comp finally sent me to a doctor for a tendinosis of my left hip. He told me work comp would pay for PRP, but I must do a steroid injection first. He avoided my question regarding adjusting for my age. His website says they use pure PRP. Does that sound okay? Well, a steroid injection will damage the tissue, so you wouldn't want to do that at all, even first, because, for example, we know that a steroid injection in the hip dramatically increases the need for hip replacement. We know that it dramatically increases the infection rate if the person eventually needs a hip replacement down the road. We know that it can destroy tendon tissue. So we wouldn't want to do something to hurt the tendon. As far as using pure PRP, I think they're talking about M-site. So if they're talking about an M-site kit and they're double spinning, you would want to get the platelet count in that 10 to 14x over baseline range. So you've got to ask if they know how to use the kit to do that. Most clinics won't. Some of the more advanced clinics will. So that's the best I can tell you. But just in general, I'd probably run away from this particular provider if they believe that doing a steroid injection is a good idea, because if they're talking about the usual dose milligram, and it's possible they're talking about low dose nanogram, but it's usually the milligram dose, then that's going to dramatically harm the tissues. So you wouldn't want to do something to harm the tissues and then do something to try to fix the tissues. That just doesn't make any common sense. Diana, can you explain again briefly how PICL triggers healing of the alars and transverse? Because ligaments can heal and decrease and overhangs can be seen. Does this mean the ligaments have returned to the original state of strength and flexibility? Yeah, Diana, I don't think we'll ever know the answer to that one in that detail, meaning that in order to do that, you would need destructive testing like we can do in animal models. So we're never going to get there. But we can certainly say that we have patients that go back to their normal daily activities and seem to be just fine and move on with their lives. But like I always say, the likelihood of that outcome depends on how long that person has had CCI and their level of functional disability. So if we have somebody who starts more functional, they're more likely to get completely functional. If we have someone that's starting at a very low functional level, they can barely do anything, they're less likely to get completely functional. But we'll never know without destructive testing whether or not the ligament returned to absolutely normal. The closest we can approximate there would be something like the MRI studies we've done with bone marrow concentrate for the anterior cruciate ligament, where we do see anterior cruciate ligaments returning to normal MRI signal. Biggest problem with these ligaments is in the upper cervical spine is they're much harder to see an image. Finn, what ligaments typically contribute most to a low CXA, say after whiplash? So that's going to be posterior ligaments definitely play a role in that. Let's see if I can share this. And maybe I can draw on this. Hold on a second here, Finn. I'm going to share my screen to see what I can get done here. See if I can explain this better. Okay, let's give this a shot here. Yeah, I think this one should work. Okay, so if you think about a low CXA, so a low CXA means we're going to go this way, and this is the CXA, clavoaxial angle, that's going to collapse, meaning it's going to go less than, let's say, 125. Now, you can pick that number at 120, 125, 130, but it's going to go low. Now, there's a couple things that would allow that, right? One of those things that'd be pretty important is actually highlighted here, and that is the tectorial membrane. So we'd have to be able to get that. The only way we can get that is through the front and a PICL procedure. Now, the good news about that flexion problem, meaning the CXA is collapsing or going too far down in flexion, causing too much stretching of the spinal cord, is that these posterior ligaments are also important. So you'd be looking at the posterior lateral occipital membrane, you'd be looking at the nuchal ligament, the vertebral dural ligament, and perhaps a little bit of the supraspinous interspinous ligament, those all being involved in and connected to some degree in reducing the amount of head rotation in neck flexion. But there's going to be anterior ligaments involved as well. So the first thing you would do, obviously, is try to hit those posterior ligaments. If that doesn't get rid of the issue, you can always come from the front and get the anterior ligaments that are involved. So hopefully that explains it a little better. Okay. Robert, I find there's a lot of attention to lateral overhang, but I don't hear much about skull sliding BAI translation other than from very few surgeons. Really, do I ever see this reviewed on DMX? Yeah, the problem is it's a lot harder to look at on DMX. So that's going to be actually what we were just talking about. Let me go back and share that again so we can get back to where we were there and go over that a little bit in more detail. So the skull sliding stuff was this type 1C translational instability. And this one is interesting because here again, let me go ahead and get a pen going here. We're talking about exactly what you mentioned, the skull sliding this way or this way. So we can sort of draw a line from the basion or clivus here all the way down to C2. And we can track that line, for instance, in extension, and see that it goes backwards. And the tolerance there is about 1 millimeter. Now, there's more to that story because here we're also talking in all likelihood about some abnormalities of the C0C1 joint. Because if we have a deep C0C1 joint, that's going to prevent that skull motion from occurring because it's going to be a bony block and preventing that motion. So most patients that have this type 1C have a shallow C0C1 joint like that. And so that allows more of that skull sliding to occur. So it is important. I make this diagnosis all the time. I would say what percentage of our CCI patients that come in the office do I make this diagnosis on? Oh, probably 1 in 5, somewhere in there. We see a lot of it in HEDS patients, and we always look at that C0C1 to try to see if there's a flat 0-1 there. So let me stop that sharing now and go back to some more questions. Stacy, as migraine meds, HOV, a monthly injectable, okay to use concurrently with PICL for CCI? Yeah, I mean, the answer is nobody really knows. The newer migraine meds that we're talking about act very differently than the older meds. So, the big concern here for this one is going to be that it's a biologic. And what I mean by any drug that ends in MAB or UMAB as a drug name is a biologic anti-inflammatory. So I would imagine that this particular one probably has a blocking of the acute inflammatory response, which could be a problem. Now, the concept here is this is an anti-CGRP, but again, since it's a biologic, it's in the same drug class as many of the rheumatoid arthritis anti-inflammatories are. So that's one I would be pretty careful with in any kind of regenerative medicine procedure for that reason. Andy, isn't facet capsular tears a normal part of the aging process? If so, we're developing some laxity in the upper facets. The huge deal if the main ligament in the front and spinal cord are intact. Andy, that's an interesting topic and one I think I covered, not too long ago, maybe 2 or 3 Facebook Lives back. So you may want to go backwards and look at that. What I did there is to look at the prevalence by cervical level of osteoarthritis, because when there's instability, osteoarthritis happens over time. And you're correct when you're referencing the mid and lower cervical spine. We know that the prevalence of osteoarthritis there is age dependent. So for instance, if we take a 50-year-old we're much more likely to see osteoarthritis at the C5-6 facets and loose facet joints, quote, degenerative instability, than we would in a 30-year-old. The one level that didn't play by those rules, and they didn't look at 1, 2, and 0, 1, but those are going to be in a similar category unless you're very old, is 2, 3. 2, 3 was not dependent on age, meaning that the motion at 2, 3 and the stability was largely preserved. So I think the answer to your question is once we get to 2, 3, based on an old study, now 20 years old, by Lin et al., L-I-N et al., all you get is 1 millimeter there. And if you've got more than 1 millimeter of translation at 2, 3, then you're unstable. So 2, 3 is the one that breaks the rule. 0, 1 and 1, 2 can get osteoarthritis as we get very old. So mid-lower cervical spine, you can start to see it, 35-year-old, 45-year-old, 55-year-old. When you start to get into the very old, 60, 70, then we start to see more prevalence of high upper cervical instability. So if you've got a 35-year-old patient with bone spurs in the high upper cervical spine, you're probably looking at the result of trauma, just playing the odds. If you've got any age patient with C2-3 instability and or osteoarthritis, you're looking at probably trauma, given the data that we have right now. But again, if you've got a 40-year-old with 5-6 osteoarthritis and degenerative instability, pretty darn normal. Amity, when DMX states that right C2 axial rotation of 24.5 degree and overhang of 4, can it be classified as atlantoaxial rotatory subluxation? Does PICL help correct the rotatory misalignment of C1, C2? Yeah, the overhang of 4 millimeters, assuming that, as we talked about before, there's also movement of the dens within the atlas, would indicate instability that type 2B, which is that atlantoaxial rotation. So the fact that you're seeing rotation there is a result of alar ligament injury. As far as getting the rotation back, that's why we almost always, not always, but we try to work with upper cervical chiropractors who can keep that in good alignment as we heal those ligaments. Robert, surprised the LAOOL ligament is in complete anatomy. Oh, I don't think it is. Robert, let me know if you find it in there. I drew it in. So that's complete anatomy, what I showed you, but I drew that in. I don't think it was on there initially. At least I couldn't find it. Maybe you can find it better than I can, but I couldn't find it. No, I drew that in on top of a complete anatomy picture. So that's how that got in there. But let me know if you can find it, because I couldn't find it in there. But complete anatomy is a little strange that way when it comes to ligaments, meaning that you can't really step back ligament by ligament by ligament like you can some of the other structures. It's either sort of ligaments on or ligaments off. So that could be part of the problem. Brian, if Regenix C intradiscal didn't work, would it be advisable to try intradiscal PRP in the future? Do you disagree with Gregory Lutz's deep love for intradiscal PRP? No, Brian, I think intradiscal PRP is good stuff. I think it can help a lot of people. It's just much less powerful than Regenix C intradiscal based on my clinical experience of working with both. Dr. Lutz wouldn't have any experience in working with culture-expanded mesenchymal stem cells interdiscal, so his only experience is from the one, PRP, which can be very, very helpful in a lot of patients. But, you know, I've got experience now almost 20 years using both intradiscal, and it just doesn't have that impact. So if Regenix C intradiscal didn't work, I think it would be very unlikely, I never say never in medicine, very unlikely that a PRP injection is going to do the trick intradiscal. But hey, like I said, I never say never in medicine. I've learned, I'm old enough to know never say never. Vivan, what's the role in C2 rotation of 18 degrees and trigeminal nerve having changes of vision, seeing orange? Doc says it's silent migraine with aura, but I have posterior neck and face paresthesia without pain. Well, the CT rotation of 18 degrees by itself, I don't know, means a lot because you can see that with things like scoliosis. The bigger question would be, is there craniocervical instability? And we can't get there from that measurement. Trigeminal nerve would usually not be involved in vision. So you might have other things impacting vision. So for instance, I think I've done Facebook Lives on how the sympathetic chain and the sympathetic afferents within the cervical spine can impact vision. But as far as seeing orange, that's a new one. That's not one I've heard a lot of in the CCI population. Not saying it's not possible, but just saying that's not one I hear a lot of. Tony, hello, Dr. Centeno. I saw one of your older videos where you mentioned patients that have repeat regenerative medicine procedures often take 2 steps forward, 1 step back. Does this mean repeat PICL patients lose some of the ligament progress they gained from the previous PICL? Yeah, so I think what you mean is the concept of honeymoon period and then backsliding and then improvement. That would be the most common thing we see. So what that means is in patients that have a lot of instability, and I've felt this myself, I have some knee instability. So for example, for the first 10 days, maybe a week after they injected my knee ligaments, my knee felt fantastic. It felt stable. Then that acute inflammation went away, and so the ligaments weren't so tight. Then it took 3-4 months until ligament remodeling kicked in. And it's only recently, I probably had that injection now, 2.5, 3 months ago, that I'm starting to notice that a lot of that instability is really going away. So you could call that 2 steps forward, 1 back, meaning that I may not get to that place where I was in the honeymoon period, and my final result will probably be less than that, but that does tell us we're on the right track in tightening down that ligament. So we need to go again. I think a lot of the PICL patients fall into that same category where they have this fantastic honeymoon and then it kind of backslides and then they make some progress. So I think that's the most common thing we see. Phrygianic senior discal didn't work well for a 5-1 with mild DDD, small bulge, small tear, but disproportionate symptoms. Would be advisable to try. I think I got that one already. Duck P, to follow up on the disc bulge question, I get some mild traction done where the disc bulges are, and the deep neck flexor isometrics and got instant stability. Is this a good sign? Yeah, that's a really good sign for sure. That's a good sign. I think that there's some muscular instability there for sure. And there may be some nerve irritation because when you get mild traction, that can take the pressure off of that nerve. If you take pressure off that nerve, then the stabilization muscles are going to work better. So those are all great signs. Amin, thanks so much. Your answer gave me a lot of relief. My symptoms could be anxiety. As many doctors told me, I didn't believe them. God bless you. Happy to help. I'm probably butchering your name. I apologize if I am. Brian, is it known whether puncture wound in the disc heals after intradiscal injection? Yeah, Brian, that's an excellent question. I don't think it's known for sure. But I tell you, we certainly changed the way we do discography. Now I will only do biologic discography. So what that means is discography is when you inject the disc and pressurize it with contrast to make sure you're in the disc and then also to see if the disc itself is causing pain. I have that same concern. So I'll only pressurize the disc now if I'm injecting at least PRP. The concept being I don't want to put a hole in the disc unless I can document that that hole is going to heal. But no one really knows. That's one of the reasons why I'm not a big fan of the Kevin Pazza approach where they're using a 17 gauge harpoon. It's not even a needle. I would call it a harpoon to put fibrin in the disc because you're creating a huge, massive hole in that disc. We use a 25 gauge needle to enter the disc. So the difference between those two is a 25 gauge needle is about 20 times smaller, something in there, 10 times smaller than a 17 gauge. 25 gauge needle is a little piece of thin spaghetti that needs an introducer needle to be able to get into the disc. Whereas a 17 gauge needle, I would only describe as a harpoon. So be very careful about that. I agree with your concerns. Diana, is it safe to inject dextrose above C2? Heard of doctors using all the safe equipment, etc., but was surprised to hear dextrose being used. Yeah, so a couple different things to unpack there. The first would be talking about what is safe equipment above C2. The only thing that should be used to inject above C2 with any depth would be C-arm fluoroscopy with contrast and digital subtraction angiography, and someone that has an intense amount of experience in injecting that area, meaning they've done that hundreds and hundreds of times. And they do it at least dozens of times every year. So that's what that looks like. It is not ultrasound. It is not someone using just an X-ray to put the needle sort of in the vicinity. Then we get into dextrose. What does dextrose do? And one of the problems with hypertonic dextrose, so 12.5% dextrose, or 10% or 15% common prolotherapy type dextrose concentrations, is that it can be neurolytic. So that means if you were to inject it on a nerve, it can damage the nerve. It could also damage an artery, in that case, the vertebral artery. It would also damage neurologic tissue, i.e. if you injected into the vertebral artery, it would go and damage the back of the brain. So the answer is you can do that, but you would have to have all of what I described to do that safely. Anything else is just high risk, but it's done. So the number of people out there that are injecting above C2 that qualify is like 5 in the US. Not many would qualify in that category. So be very careful there. Most of the places you would hear and think are qualified would not be qualified, in my opinion, to do that safely because of risks. Chris de la Costa, does a broad central disc herniation in the neck imply that the PLL is injured or in some way torn? A broad, no. So it's a broad-based, so the PLL is like a piece of duct tape that runs down the back of the vertebra inside the spinal canal, in the front of the spinal canal. The disc is right in front of that. So if the PLL is injured, you would have more of a disc herniation. A broad-based disc bulge would assume that the PLL is intact. And then the PLL can also be intact where it comes out posterior laterally. So no, those two things may not be associated. Jim, I messaged you a while back on how I saw good progress. My imbalance with laser pointer exercise, my PT is having me do small neck rotations with light resistance tied to a neck harness. Good idea. Yeah, Jim, I would only ask you just to go slow. And so, for instance, you might try neck rotations with even lighter resistance, see how that goes. Then maybe add in a small amount of weight, see how that goes. Add in a little more weight, etc. So that's the only thing I'd say there. Amity, will CT with rotation always demonstrate type 2 instability? No, it's very it's highly specific for type 2B C1C2 rotational instability, but it is poorly sensitive. So what that means is a medical test is highly specific when it can nail the diagnosis and eliminate things that, false positives. meaning something that looks like the person has the disease, but they really don't. It's sensitive when it can very often detect the disease when it's there. The problem with CT, rotational CT, is it's poorly sensitive. So we see a lot of people with C1CT rotational instability as confirmed on DMX who have normal, who don't have the more than 56 degrees of C1CT rotation as defined by Dvorak et al. In the 90s. Jennifer, he said they want to prove the PRP unless steroid fails to help first. Is there all I can cite? And yes, he says MSite on his website. Yeah, I don't know, Jennifer, as far as, I mean, there's lots and lots of research out there. You're certainly welcome to go on the Regenix blog. If you just type in corticosteroids, you will find probably 10 different articles about corticosteroid side effects. And you can certainly, some of those are referenced, so you can certainly give him that to read. Like I said, if they're talking about milligram dose steroids, and usually that's what they're talking about, that's considered extremely high dose, even though it sounds milligram isn't high dose. Then I think I'd just find another doctor, because, I don't know that it's appropriate to play the game to try to get it covered if playing the game means destroying tissue and then trying to help tissue. That would go against my Hippocratic oath. That's why we don't use any milligram dose corticosteroids in my practice. We haven't for many, many years, because the literature is very, very clear that they damage tissues that they're injected into. Amity, what posterior ligaments are injected in upper cervical workup? How does it help type 2B instability? If you've got type 2B instability, normally we would move forward with a PICL procedure. Now, in patients where we're not sure that the type 2 instability is causing their symptoms, then we would look at treating all the posterior ligaments. So that's going to be all the ones we talked about before: nuchal ligament, vertebrodural ligament, supraspinous, interspinous ligament, those lateral AO ligaments, etc. But we'd probably also get the C1, C2 intra-articular facet using fluoroscopy, contrast confirmation, digital subtraction angiography to try to make sure, try to treat that joint, because that joint is the one getting beat up in type 2B. Amber, my head moves on a weekly basis. Moxiput is always out of place at my AO appointments. What ligaments are treated in order to fix this movement? That I can't get to a CCI type with that description. So that would require a workup to get to that answer. And then I've only got 5 more minutes because I've got a hard stop and a meeting at 2 p.m. Mountain my time. So I'm just going to take everything I can get to here in the next couple of minutes. Amity Rehab Services, does lumbar DDD procedure help with back issues with herniations and stenosis? Yes, in general, that could be very helpful. Dana, sertraline, safe to use, going to impact PICL procedure outcomes? Not usually something that would be considered to be concerning. So usually not. John, any supplements I can take prior to PRP to help boost results? Yeah, that has a lot to do with the individual patient. So nothing specific that I could recommend in general. Jason, if PRP, Prolo, et cetera, is repeatedly performed enough times on a ligament, can it be ever made stronger? Total number of pounds of force you damage is slightly higher than a normal ligament. The ligaments get bigger each time you treat, and presumably they get stronger too, right? Yeah, not really. You got to realize that the strength of a ligament is determined by its chronic constant load. So the answer is you're really never going to get a ligament that's stronger than that load dictates. So the answer is no, not for very long, meaning that the body is very good at getting rid of tissue it doesn't need. If you just look at it from an evolutionary standpoint, why would you carry extra tissue? It's just extra calories that you've got to get during the day. So the answer is really can't work that way because the ligament strength is determined by its chronic load in that specific area. Amity, does lumbar DDD procedure help with chronic back issues with disc bulging and central foraminal stenosis? It can. Amity, how much gap is recommended between two procedures for posterior injections? Normally 4 to 8 week time frame for that type of approach. AT, I've been diagnosed with CCI with 5 millimeters overhang and lateral flexion both sides on DMX. I'm about to undergo CBP therapy. We see Dr. Katz research. How much can CBP alone fix overhang? You know, I think what it can do, and I think Dr. Katz has demonstrated this himself, is that if we improve the curve, we can take the load off of those alar ligaments. And by taking the load off, some of them will heal. So I think it's an excellent first step to try to see if your body will heal it. Now, there's lots of other factors in there, but in general, I think it's a good first step. Amber, what type of instability or laxity causes tinnitus? I have constant hissing, but when I lay down, it's obvious loud heartbeat, thumping sound. So tinnitus, most common thing or most common cause, we believe, would be internal jugular vein compression. That could be lots of different types of instability, like the 2B that we're talking about. Yes, I just looked for it when you mentioned it. Maybe you got them to add it. Could be. I don't know. I'll have to go back and look, Robert. That's great that they have it on there, though. Absolutely fantastic. Ulysses, can the nuchal ligament safely be injected with ultrasound X-ray guidance by palpating? Nuchal ligament can be safely injected with ultrasound or X-ray. You'd have X-ray with contrast. So yeah, that's one that can be safely injected with both of those. Diana, do you have to move your neck to feel muscle strength, or is it okay if I sit upright without support to support less muscle atrophy? There's certainly a postural component to muscles. So I think just spending more time upright without a neck collar is a good first step. And then this will probably be my last one here, or maybe one or two more. Jason, do you know of some factors that might affect how structurally sound new collagen is when it's laid down? Yeah, well, loading is a big one, obviously. Your ability to heal, stem cell content in the individual ligament, getting away from things that might damage the ligament, like corticosteroids. We've had that conversation. So all of those things would determine that. Then there's obviously congenital factors like people that produce defective collagen, stretchy ligaments, etc. And then finally, there's the inflammatory mix that the collagen is being created in. So we know, for instance, from cartilage healing that we get chondrocyte hypertrophy in systemic inflammatory scenarios. So you want inflammation acutely. That's a critical part of healing, but you want it to go away or resolve fairly quickly as well. I'm just going to take one or two ones I haven't seen before. Amber, this is an excellent example. I was told that my fullest potential after prolo would be reached in a month after treatment. I had 7 treatments, all 1 month apart. I feel even better 5 months after my 7th prolo. Yeah, Amber, that's pretty common. Really, it can take months and months for ligaments to fully heal. Robert, is the LAOL visible on ultrasound or other imaging? No, I think you've got to look at movement to see if it's intact. Barely see where it's kind of supposed to be on MRI. Definitely can't see it on ultrasound. And then this will be my last one. I've got a lot of great questions today, so thank you for those questions. Marcia, how long would it take to be able to say if a vagus nerve hydrodissection had any effect? I read it could take several weeks. Yes, you're relying on both nerve growth factor and neovasculogenesis, so that can take several weeks for sure. So guys, thank you so much for all your fantastic questions today, for lots of people getting on here and asking these great questions. I really appreciate them. They stimulate debate, they stimulate discussion, they help people learn. So thank you for everyone who participated, because you make this whole thing that much better by asking these great questions. So I will be here this coming Monday, and I will see you same bat time, same bat channel on Monday. Thanks so much, and have a great weekend.